Welcome to Kookie Podcast International. This is a new podcast in the field of manual therapy. It is created as a space for dialogue within an international professional community. The intention is simple: to slow conversations down, create the conditions to question assumptions, and make complex ideas clear and usable in practice. This first series begins with a conversation with Oliver Thompson following the debate sparked by his article "What's Wrong with Osteopathy?" Rather than reacting to fragments or online commentary, I wanted to slow the discussion down and explore the ideas more carefully. What happens when criticism becomes public? How does social media shape professional identity? And what does it mean to question a profession from within? This conversation is not about defending positions. It is about understanding how we think, how we are, and how our professional culture evolves. So here's my conversation with our colleague, Oliver Thompson. Hello, Ollie. I'm happy to have you here with me today to discuss important topics about osteopathy, which are very actual. And my first question, Ollie, is about the "What's Wrong with Osteopathy" article. And I wanted to know, what was wrong with Ollie at that time? What triggered you? There must have been something that triggered both of you, Andrew and you. And so what happened at that time?
Hi, Marco. That's a good starting question. I think it was 2023 we wrote the paper from memory. I think that's when it came out. And thinking back around that time, it was just, I think it was a combination of things. I think probably we were spending too much time on social media, Facebook groups. There was a particular group, Osteopathy Works, which I think still exists. And that's kind of, I think, that's a really, that gives a terrible, that's the worst of osteopathy in my view. Or social media can be either the best or the worst of all of us. But I think thinking around that time that we were probably interacting a lot with some of that content, and there was lots of, and because it was off the back of COVID, I think also around that COVID time, there was lots of professional discussion around all the stuff that came with COVID, the poor science, the poor thinking, the pseudoscience. And so I think it was a kind of a combination of some of those forces. I think I remember at the time feeling very frustrated personally. So I know it was my idea to write the paper, and I got to a certain, I remember the Hammersley paper, the "What's Wrong with Ethnography" paper as a PhD student. And I remember reading that when I was learning qualitative research, and somehow a thought popped into my head to try and write, to document some of this frustration using that framework. I got so far myself and I just couldn't, I had the idea of the paper but couldn't finish it. And so I approached my friend Andrew, my colleague at the time at the old University College of Osteopathy, the UCO, because he was pretty familiar with some of the social sciences and some of the work he's done. And he was really valuable. And we shared very similar views, actually, and he wrote really well. But I think that it was really probably frustration. Whether I'd write the paper now, probably not. I'm probably less frustrated in a way, not because I don't think the issues are gone, but I'm just probably less sensitive, older. I'm older. I'm a few years older, so I'm not so bothered by this stuff. But I think going back at thinking now, I can't remember the exact time, but there may have been a year or so before, I think, there was something called pericardial gate. You may not remember it, where there was some discussion on Osteopathy Works Facebook group around the ability to reliably palpate the pericardium. And not just reliably palpate the pericardium, but to affect change in the pericardium. And I guess before that, you've got to reliably palpate dysfunction, whatever a dysfunctional pericardium means. I remember reading that post in Osteopathy Works, the Facebook group, and the replies from that were very supportive, and this is a great thing, and yes, we can do this, and you should put your hands here. And I just had an out-of-body experience and thought, this is just this is madness, and this is bananas. It really was. And I remember I went onto Twitter. This is when Twitter was Twitter. And I think I made a statement like, at this moment in time, there are regulated health professionals that utterly convinced that they can palpate and change the pericardium through the chest wall. And that wasn't an untrue statement. That was completely true. I mean, that was true in so much as there were regulated health professions as osteopaths, and that's what they believed. But I put this post up on Twitter. It got lots of traction. Lots of people, physios and chiropractors, were saying this is incredible. And so it got lots of retweets, I suppose. Off the back of that, I was kicked out of the Osteopathy Works group, which was fine. But it was around that time, I think, that there was. So I think, in short, I think social media probably had a lot to do with it, or osteopathy social media, and that's the paper emerged from that. But there were some probably antecedent conditions leading up to the paper.
That's what I wanted to know. And just for the record, when you've been kicked out from the group, did you receive any message just to explain why you were kicked out? Or?
Yeah, I did. I didn't put a screenshot of the Facebook post on Twitter. It was just literally me just writing what I said. And I think the view of the moderators was, I've somehow, that it's a closed group, even though there's 10,000 members or something, I don't know. But nonetheless, I let as we say in England, the cat out of the bag, or I said something which was discussed in confidence and I put it out onto another platform. And to be honest with you, lots of other health professionals just laughed and thought, this is crazy, this is ridiculous. So in my view, I did nothing wrong. It was entirely anonymous. And it wasn't an untrue statement. I mean, if you hold those views and you're so confident, then you should be perfectly happy to have them shared. Mm-hmm. I mean, clearly, the post was written my post was to sensationalize and to expose some of this stuff. But nonetheless, I was kicked out for those reasons. I was subsequently invited back, but I was just said, no, thank you. I didn't reply. I was very encouraged that I had many supporters. It was nice to see friends and colleagues say, justice for Ollie, maybe some march down central London. But there wasn't. But I think that it was a mixed view around freedom of speech, if you like, and keeping some of these ideas contained within the profession. And I guess the What's Wrong paper was probably in reaction to that. I mean, it was my Twitter post on steroids, if you like, that rather than just being a single message, it became a whole paper.
It's true that if I have to position myself here in this podcast, it's not to be an Ollie advocate, it's to be an advocate of diversity. If I can, I may be a bad advocate about that, but to me, it's important that people produce things and thinking like you do. It's important to preserve some kind of diversity too, and some kind of safety, because diversity doesn't mean you can do whatever you want in the setting of a regulated profession. We have some kind of responsibility. We have people's lives in our hands, so we are not allowed to do everything. We cannot say everything. So there are boundaries, and still within those boundaries, there may be some kind of variability. What struck me at that moment is the harsh way in which you have been treated by people who pretend to be very subtle, to treat very subtle things, to treat with life, with the universe. And I've been one of those, I have to confess. And the problem is that you expect from those people very much more understanding and love and to be welcoming. And that's a problem. I have experienced the same myself. I've tried to shake a few trees. I don't know if you say it in English. And I've received very harsh comments from people who are known to be very subtle and things. So to me, that's it's not okay to treat ourselves. It doesn't matter in which field you are. You don't treat people who think differently so hard. What triggered me in defense of Ollie, it's okay. Whatever Ollie says, you don't treat someone like that. If you have something to say, you can answer it, because it will bring us to talk about social media and the literature. What I appreciate in your position is that you are a worker, which means you're not a hater on Twitter who tweets every morning just to do some bashing, or you're taking the time to reflect, to construct your thought, to put it down, so you expose yourself and your thought with references. And so we should play that game. We can answer There are answers that have been published. That's why I think it's interesting. And if we go to the field of just in fight in the mud, nobody gets anything from it. So that's why I appreciate that you try to question things. And then the problem is that nobody answers on that level, and they answer on the personal level. That's a problem. I don't know. What's your thought about this?
I think you're right. I think the paper was it was an intellectual exercise, really. It was taking dispassionate views. So Andrew and I, despite both being osteopaths and clinicians and having some affinity for osteopathy, we weren't precious about it. We thought, right, let's examine these ideas. Let's examine osteopathy purely as an idea, as an idea with a set of premises and behaviors which are tied to those ideas. Let's just look at those and look at those critically and not be worried about kind of blowback, offending anyone. But at the same time, we didn't intentionally set out to be offensive or unkind. As you said, that it was an academic paper written by two academic clinicians, which for an audience of some were clinicians, some were academics. And actually the academics really liked the paper. From an academic point of view, we've had some really favorable emails and thought this is a really good, interesting paper, well done, etc. And I think some of the clinicians found it quite challenging because it was so critical. And I can understand, I mean, maybe at the time I didn't, but I can understand that, those that have invested time, money into this profession, to have a paper that comes out to list almost like a menu of bad ideas within osteopathy, I can understand that it can be quite jarring, quite difficult to digest. So I can appreciate that. At the same time, I would also hope that those same clinicians would appreciate that part of being a professional is to think about what you do and not just think about the great things that you do, but how you can do things better. And it's entirely possible that we've got many things wrong within osteopathy, and that's fine. I mean, all professions go through this process. And I think some of the response did show that in some corners of the profession, in some parts of the world, that there's a real thin-skinned, I think. There's a real lack of reflection, or reflection can only happen in one direction, to really think, well, I've reflected and yes, I've concluded that we're doing things really well. And that just doesn't really cut it, does it really? We've got to examine things in a much more, not so neutral, but holistic way. I think that's dare I use the word holistic.
It brings us to the question of the bio in the biopsychosocial, and probably we'll come to that later because you talk about the pericardium and things like these. But just to stay on the reception of your message, what I see is that since the beginning as a profession, even if the American School of Osteopathy has opened in Kirksville, so osteopathy is something that you learn at school, we have a tradition of taking for granted what has been said to us by a master, someone we consider as a master. And then we repeat, and then we become a teacher, or we become ourselves, masters that are followed by people who take for granted what we say. And this for generations and generations. And we have to admit that we have not a culture of discussion. Osteopathy isn't born in the University of Vienna in the 80s. So I don't know what's your vision about that. Probably I think that what lacks here, because the debate was not really friendly or very useful at the beginning. And I think when I discuss with my colleagues here in France, in Italy, in Switzerland, sometimes it's that they are not used to debate. It's as if they identified themselves with models. And I think the first step is just to get some distance with the models and the people who suggested them. So just to criticize the models doesn't criticize people. And what do you think about this lack of culture of discussion? Is it changing?
No, I think you're right. I think you're quite right. The history of osteopathic education tended to be, I guess in the first instance, was just small groups of people taught by Still, and those developed into colleges, not really universities in the sense that we recognize them now. And there hasn't been that diversity, as you said, of thinking. That it's not like osteopathy is sat within a medical school, for example, where there's lots of governance and intellectual regulation almost. You just can't have a crazy curriculum within a school. And this is what, on a side note, in parts of Australia where they've had to remove some of the cranial teaching from the university teaching in osteopathy, because you can't have, on the one hand, a lecture on this is how the skull works, and then in another lecture in the medical program, they're teaching a completely different way. So I think within the college system or the school system within osteopathy in the UK and in Europe, and there hasn't been that level of criticism or critical reflection. I think that's probably better. And so when someone comes out and writes a paper which does that, invariably the profession or parts of the profession aren't used to it. And you're quite right, the distinction between criticizing an idea or a theory or a model or a concept and criticizing the person, they're quite different things. And what Andrew and I try to do is to really target our criticism towards the profession as a concept, not individuals. I think for some reason, osteopathy, maybe the same in chiropractic, there does seem to be an intermingling of theory and identity that is not the case for some. I've got to keep saying for some osteopaths. I've got to keep caveating. I might remove the word some because it's too many words. But even though I'm speaking in terms which sound like I'm generalizing, I recognize that it doesn't apply to everyone. But my sense is with osteopathy that there's a real interlinkage between theory, principles, models, and identities, that you've got to live and breathe some of those ideas, and they form your sense of identity and value and kind of professional role, therapeutic scope, etc. And that makes it really hard. So because the minute you criticize the model, you're invariably criticizing the person at the same time. And like you said, somehow you need to kind of just distance yourself and say, this is, there are a set of beliefs that I have. There is a set of knowledge types that I hold as an osteopath, and we can scrutinize those. We can look at those without criticizing the person. But with osteopathy, it's different. And happy to talk about more, but it does seem to be unique in that way. Maybe because it's a kind of praxis where knowledge is kind of embedded in the doing, and maybe it comes down to palpation and this view that there's this kind of connectedness between the osteopath and the person and their kind of living system. I think that's the perception. I don't think it's true. But I don't get the sense that a radiologist speaks about themselves in the same way as some osteopaths, or maybe a physiotherapist or an optometrist or a nurse. Maybe nursing might be different. Nursing seems to have a different quality. But nonetheless, it's odd, isn't it? Osteopathy is a job. It's a role. It's a social role, professional role. But yet osteopaths take it very personally.
You talk about in an article about clinical decision making and the qualitative grounded theory. I think it is in that article that you talk about conceptions of practice. Is it right to talk about the conception of the profession first? Can you just give us how you see things? What's your vision of practice? Maybe you can express yourself from a personal standpoint, and we know from where you're talking, and which is at the same time based on some kind of research. It's not only based on your opinion. That's always what I say. Yeah. It's a personal opinion. I'm not allergic to personal opinion. I think that to have the personal opinion of an expert on that very subject, it's very interesting. To have a personal opinion of someone that doesn't have any knowledge of a subject, you just have to go to a pub and it's okay. But to have the personal opinion of an expert, even said as a personal opinion, I think it's interesting. Can you reveal a little bit of how you see osteopathy yourself, how you try to implement it in a daily basis?
That's a tough question. I practice as an osteopath. I don't really know as I say those words, I don't really know what that means. I honestly don't identify with the term. I've got nothing against it. When I'm with patients, I'm not thinking about demonstrating osteopathy or establishing some osteopathic kind of atmosphere to my treatment, or thinking, the idea of thinking osteopathically, that's a common term, isn't it? You've got to think. I don't consciously do any of that, and I'm pretty sure I almost consciously, actively don't I don't engage in my practice in that way. But nonetheless, I see patients and I try and help patients as best I can. Now, this is a long way of
Yes,
talking,
just feel
of
free to
answering.
give it.
But yeah, when a patient comes into my clinic, my stance is, what's the best way that we can work through this together? I mean, that's it. And there's no single osteopathy just doesn't feature in my thinking. There's no principles, there's no identity. I feel no obligation to perpetuate any particular osteopathicness. I've obviously got my code of practice, the things that I abide by, the ethics essentially, which I'm very allied to. But beyond that, I will draw upon anything and everything within the evidence and my experience to help that person. And so I guess some of the key ideas or the key areas are things like person-centeredness, sprinkles of, assuming it's a musculoskeletal problem, it almost always is, some cognitive functional therapy, some understanding of the person's own beliefs and their own behaviors and what their thoughts are about what's going on, to understand how they view my role, how they view their role, their expectations about care, their preferences, what sorts of treatment they think, or what sorts of management they might be looking for. And then I kind of just go from there. So my practice looks like sometimes a little bit of manual therapy, in my personal feeling towards doing manual therapy. I don't really like doing it. I don't think I'm very good at it. I do it more so because there may be a sprinkle of some kind of pain modulating effects, but it's really around expectations and exposure to movement. And so again, when I'm doing even the manual therapy, it's not an osteopathic idea using some of the mechanisms which we would use to underpin those treatments. So yeah, I don't know if that really answers it, but I'm an osteopath merely by regulation, by professional status, but I don't feel any sense that I want to. I'll be honest with you, I'm not sure it was even helpful. I've examined osteopathy quite a bit, and even the stuff around holism and patient-centered care there are better ways, better discussions around those ideas outside of osteopathy. And that's one of the things that the What's Wrong paper makes. There's plenty of literature and evidence and models and theories and practices outside osteopathy which can really enrich an osteopath's practice.
I totally agree, because since I'm an outsider. I've studied industrial engineering before, and I read a lot of stuff in social sciences and in other fields. And I find very interesting things in other fields, in psychology. And sometimes, yes, I have the same feeling that we can learn a lot from others. And the question is an identity question, and we have to address that question, because it does mean that if tomorrow I meet a physio or a chiro, and I find it very interesting that all these people work together, are there still any boundaries between these professions? If we look at the risk, I don't know if it is a risk of all these boundaries being teared apart and just tear down this wall, as we say.
Tear down this wall.
And there's only one profession. I know that it's a thought that I came across sometimes. What if I meet a physio and he says exactly the same thing, which is, I'm in 2026, I receive a patient. It's a person. I would like to treat and to receive it as a person and to provide the best care given the available literature in 2026. Will it be different from what you say from a colleague chiro? What do you think about these boundaries? I've read a lot of interesting things about fluid boundaries, but fluid boundaries is still boundaries. Yeah. And what about no boundary at all? Can you position yourself?
Sure, I think you're speaking to some work that PhD student that's doing their PhD on this, Joshua Tulloy Wallace,
yes,
who's a physiotherapist in Queensland, Australia, and has done some really lovely ethnographic work, so observations of osteos, physios, and chiropractors that work in the same clinic, and trying to understand some of these boundaries and how they're maintained. What do I think? I mean, I think my view on this goes something like, it used to be that these three different professions, and I know that there are others in in Sweden they've got naprapaths, and Norway have their manual therapists. I get that, but if we go with the three, chiro, osteo, and physio, that they somehow crudely give the landscape some kind of shape, right? So there's some crude separation of practice from a position of a patient or the public. So if a patient is looking for a certain type of care, there's some signaling as to the sorts of care that they can get depending on the clinician they go to. That's the first thing. So I guess if you remove those, but if you just had one profession called whatever, manual therapy or musculoskeletal care, that might remove the sense of choice actually from patients, maybe. And that's that. Think about risks. That might be a risk. Some might say it's better not to have that confusion, because patients say, "Oh, I don't, these three professions, I don't know who to go to." It's like having three types of dentist. I mean, imagine if you had three professions that all did dental work. You'd be like, "What do I do? I just want some help. I just want to see the person that's going to help me, sort me out." So I think, I can see benefits. Whether politically, I think it'd be really hard. I think there are lots of forces that maintain some of these boundaries, and it's in the interest of professions actually to protect knowledge, to protect skills. If we look at parts of the world where osteopathy is still kind of vying for professional regulation, parts of Scandinavia, parts of Europe, Canada, you've got to demonstrate quite clear boundaries. And yes, you've got to probably also suggest that you're open to collaborating and supporting the wider healthcare system. But if you go in to government and say, we're pretty much the same as the regulated physios, there's no real epistemological difference, we do the same kind of thing, it makes no sense. So you've got to kind of really speak to the USP, the unique selling point of your profession. And so I also understand that I'm from the privileged position of the UK, where osteopathy is regulated. I doubt we can be unregulated, but we could be, as a regulated professional, it's easy for me to sit here and say, there should be no boundaries, and I'm the same as a physio. But I get, if you haven't reached that point of professionalization, you're going to want to have some sense of closure of your professional group and not be seen as being the same. So I can see that too.
While you were talking, I was thinking about how I see things in that way. Because when I got involved in the professional doctorate with Stephen Tyerman, he just asked us a question, asked us to reflect on that question. What makes us as osteopath unique? And we all go through these answers that, yes, but we consider the body as a whole. And Stephen said, okay, but in acupuncture also, a chiropractor also, yes, but we only use our hands. Yes, but the chiropractors too, and also the massage therapists. So, and in fact, I came to the conclusion that probably what makes our identity is like as if it was our flows, and it's also valid to chiros. What makes a chiro unique? It's all the flows that that have been passed from generation to generation.
Yeah.
So at one moment we have to say, okay, we have a paradoxical situation where what makes us unique are this set of things. In this set of unique things that makes us unique, there's a lot of bullshit, which is okay. It's okay because there's bullshit everywhere. At that time, it wasn't bullshit. And with hindsight, in the 20th century and the 21st century, we cannot only build our practice on these statements. But the problem is that if we leave the bullshit, we lose our identity. And so I prefer keeping my identity. Yeah. And this is very complicated question to answer. I don't have an answer myself. I don't know.
No, I don't either. And looking at the UK example, where osteopathy is mostly now in universities, and there's been the courses are generally more contemporary. So there's, for want of a better word, a removal of bullshit, or at least most of the bullshit. Mm. But then you look at the program and it's like, well, this is kind of a professionally agnostic manual therapy, musculoskeletal care degree. where's the spirit of osteopathy gone? And I think whilst I'm perfectly comfortable with that, for enrolling students, so there's two issues. One, students are like, well, I want some of the magic. The magic's gone. I want some of those, those amazing claims and skills that I've heard osteopaths can do. And likewise, the profession of which these students graduate into aren't ready. They're like, well, hang on, we need you to be able to palpate the fourth ventricle. And with these students coming out, they can't do that. They're just physiotherapists. They're not osteopaths. And there's a real tension there. So I think it's really challenging. I don't think any of this stuff excuses. I don't think what we should do is how quick we better keep the bullshit in. I think where things are untrue and when there are better, more scientifically accurate explanations for things, to ignore those, I think there are real ethical issues there. But I think that the way in which we describe the profession, how we talk about the career of being an osteopath, what it means to be an osteopath, I think we've just got to be clearer and better at communicating that. I haven't got necessarily a great explanation on how osteopaths should see themselves. And I don't think there is anything unique. I think it's, I think you could say the same thing about physiotherapy. There's nothing unique about physio. There's nothing unique about, chiropractic. They all face the same question. It's a horrible question to answer from any profession. Yes. What makes you unique? I'm guessing a brain surgeon could probably have a good go at that and say, well, actually, I'm the only person we're the only profession in the world that can actually do this, i.e. cut open people's heads and operate in their brains. No one else can do that. Whereas when our practice is quite different, we don't have, across all three professions, we don't have ownership of those skills in the same way that anyone can prescribe exercise and do some touch-based work and to do some reassurance and all those sort of things. So it's a different ask, isn't it? It's harder to give a useful answer.
It makes me think about something where probably our opinions may diverge. I've gone through the path of thinking about the models but still, I have worked a lot with my hands and found it very important. I've put my hands on chests, hoping to provoke changes inside the chest. I've never tried to feel the movements of the pericardium. That's where there's a slight difference. I try to place myself in between the extreme positions because I've put my hands on chest, hoping to provoke changes inside, but I never thought to be able to perceive a tissue inside of the chest. I know that there are tissues inside of the chest, and this is going to bring us to the anatomical possibilism. But if someone recorded me 15 years ago, and he recorded me 2 years ago, with the muted sound, the interaction would be quite similar. Not exactly the same, but quite similar, at least the manual part of the interaction. But if you put the sound on, things are very different, but still, what I consider, this is probably where we don't think the same. I consider if we mute the sound, what osteopaths do with their hands using complete bullshit models, I think that there's a baby in the bath, and I think there's value. I still think with all the things I read, and I read your articles too, which are inspiring, but it's not because I read Oliver Thompson's article that I stop to believe, I say believe, in the fact that, yes, still with my hands, I have this personal feeling that it may help. I don't know the mechanism, so my standing point also as a teacher is that when I don't know the mechanism, I don't invent a potential mechanism. I say, I don't know, but I try to find some plausibility, but not in the anatomical sense with the fibroblast and things like that. So, but I still think what I do, that thing with my hands, and still I ask the patient, I have not the impression of dreaming. The patient still is able to express his feelings, and it goes in the same way as what I feel. I don't know what I did, but it brought some changes that can be felt by the patient. We all agree. I didn't ask him or her to believe in something while doing it. And so, but the reference, do you still think that, what do you think about the manuality Because I have the feeling that it has been voided probably too much from my sense.
What do I think? I mean, I think, like I said, I use touch and hands-on in my practice to a more greater or less degree. Some patients I don't touch at all in the manual therapy sense, and that's guided by their preferences, expectations, what I think the kind of care that they're looking for. I think thinking about your example of you touching chests and not really thinking much about the pericardium, but nonetheless, and you not being able to construct, or you're not aware of a plausible mechanism, but yet you still do it. And so I think you recognize that you can't identify a plausible mechanism, but yet you and the patient still perceive some kind of value in that interaction or that intervention. And I think for me, I stop at the plausible. The fact that I cannot, for the life of me, think of how this could work. I'm like, well, why the hell am I going to do it? Like, it makes that, and that's not to criticize you. It's just I stop at. I'm like, okay, well,
it's okay.
Yeah, I'm genuinely not criticizing you. For me, it's just, okay, well, I can't think of a way that how that would be helpful. Just like I can't think of a way if it would be helpful for me to, sing a song or do a dance in the clinic room. I mean, that's probably a better mechanism for that, in all fairness, than the manual therapy. And I guess early on, in thinking about this now, I think I felt like this early on. So I think what might have happened is, if I had been continuing to do and to practice in a kind of very hands-on way, and then I was aware of the kind of the evidence and literature, I might have acquired some experience and think, actually, I don't believe the evidence, or rather, I recognize that it's not working in the way that I thought it was, but I've touched enough chests, and enough patients have said to me, oh, that feels great, I feel much better, you're fantastic, to kind of disregard that. Even though I've touched a lot of bodies, I guess I haven't acquired that experience of it working. And and maybe this is where I'm being dogmatic. I just don't think I'm missing out on anything. I just don't think it's true. I have no doubt that when you're intentionally, and because we could explain your interaction, your experience, in ways which are consistent with the literature, but really don't require any adherence to kind of structural beliefs that you sensitively and in a very confident way, in a very ethical way, in a very expert way, feeling around someone's body, their chest, in a person who is trusting in you, and you've got a wonderful developed therapeutic relationship, that I've noticed it has a profound experience in some people, and they will say to you, Mark, that I feel quite different now, or whatever health measure that they want to articulate. I think that's entirely true. I think that happened. I think you're not imagining that, but none of it requires. I mean, I think you would agree with this. None of it requires a belief in myofibroblasts or the contractile aspect of the fascia. I think these are non-specific touch-based effects, which are short-lived in that moment. And I recognize it. So in summary, how I view touch and manual therapy, that it has some, cognitive impact on the person, some experiential impact. Whether you get the same effect if you touch their, lateral malleolus, probably not, because somehow there's been some convergence on the chest as being a meaningful part of the body. They've got chest pain or whatever their kind of health complaint is. You've both agreed that the chest carries some meaning for them, and that's why you're touching their chest. And if you touch their lateral epicondyle, but they had anterior cruciate pain, I think it might be different. I think so. Even though touch is often described as being non-specific, I think there is some kind of social specificity there, that actually, if an area means something to someone or has some sense of importance or concern, and that's why an examination, just examining the area, and all the kind of bullshit examination techniques that we do, and palpating for sacroiliac joint movement and all this garbage, the mere fact of doing that those behaviors convey concern, they convey expertise to the patient, even though it's pseudo expertise because you're not really palpating the 3 millimeters of movement of the sacroiliac joint, but nonetheless, you're conveying confidence and trust, and and they have effects. They help outcomes. So that's kind of where I am. So I just don't believe it. I don't believe it, and there's no good reason for me to believe the structural mechanistic explanations of how you described what you did, nor how I use manual therapy. And without going on, what surprises me with osteopaths, I'm generalizing, but with many osteopaths, is that when I say to them, you want to touch patients, that's absolutely fine. If you want to do your kind of very specific palpation and joint assessment, that has value. That has, as I described, that has value to the person and the patient. But it's not because of this mechanistic explanation or theory that you've got. It's because of contextual effects and trust and reassurance. They're not happy with that. They're like, no. I'm not saying they should be. I'm not sure they should thank me, but they're like, no, it has to work. And so I'm saying it works, but it doesn't work in this way. They're like, I don't care. It has to work in this way. I'm like, well, no, it can be helpful, but it's not helpful in the way. So there's this very interesting, and I think we speak about it in the paper, where the mechanism has to be true. I mean, even if you grant them the outcome is true, even if I say osteopathy helps patients with back pain, but it's because of reassurance and all those things, they're like, no, it's not. It's because of, they'll argue the mechanism. And that's quite interesting, isn't it? It's one thing arguing value, but the mechanism is tied to the value that it's not only got to work, but it has to work in a certain way. Because the mechanism presupposes that if the mechanism is true, then the techniques have to be true because you can intervene in that mechanistic chain and rotate things and move things. And so the skill, which is tied to the identity, the osteopathic manipulation, the cranial, all that stuff. So there's this interesting thing where the mechanism really justifies the skills, the professional identity, the professional and social roles. Whereas if you just say, oh no, it's just context and reassurance and regression to the mean, all those things, but it's still, you have value, that's insufficient for many osteopaths. I'm not fussed about that. I don't care. I don't need to have those mechanisms in my life.
That's one reason why I wanted to talk with you, because I wanted to confront this, because I know that you think and your thought is very coherent. And my personal question is, how can we live together and belong to the same profession and still have a lot in common and not everything? Because if we all have to think in a very unique way, it becomes dogmatic anyway, whatever way it is. So my question, that's why I want to confront and still... In this first part, we explored criticism, professional culture, and the dynamics of public debate. In the next episode, the discussion moves closer to clinical questions, plausibility, touch, and the assumptions that shape manual therapy practice. Thank you for listening. I'll see you in the next episode.